after a long day in the bleeding disorder clinic. And she also will be graduating with an MSc in internal medicine from the University of Edinburgh towards the end of this year. And we are in for a treat today. Her talk is entitled Hypermobility, Hereditability and Bleeding of Unknown Cause, a Cubist approach to impressionist disorders in hematology. So Stephanie, we're looking forward to your talk, and you can take it away with the first part of the session. Thank you.
Okay, thank you very much, Jaco, and thank you, Estelle. Just before I start, just want to confirm that you see and hear me.
Yes, we can see and hear you.
Great. Okay, so thank you for the opportunity. I'm very excited to present my presentation. It's called Hypermobility, Heritability and Bleeding of Unknown Cause, a Cubist approach to impressionist disorders in hematology. I just have one disclosure to make. I will be showing 1 or 2 pictures of patients, and in accordance with the Papaya Act, I did get the written consent to do so and share the clinical information. So I'm going to turn off my camera now. Just give me a second to do that. Okay. So, and it's not moving. Just a second. Sorry, okay, great. I'm starting off with a case presentation, and all the topics for today's talk is from this presentation. I will discuss bleeding in heritable disorders of connective tissues, an approach to vascular bleeding disorders, as well as bleeding of unknown cause. So at the start of the 20th century, a new postmodern art movement known as Cubism sought to deconstruct complex images into small geometric shapes so that objects could be studied from multiple angles and viewpoints. In essence, the Cubist artists reacted to the Impressionism of the 19th century. Now, you will agree with me that these are all rather impressionist disorders, the heritable disorders of connective tissues, vascular bleeding, bleeding of unknown cause. But my aim is to break them up and to reassemble them so that they will make more sense as a whole. So the patient I'm presenting is an adolescent female with heavy menstrual bleeding. And this picture is called Girl with a Mandolin. So it's just fitting that I will also address heavy menstrual bleeding in adolescents and women's health. So the case that I saw last year in October, shortly after I started. It was a 16-year-old female. She was referred to us with heavy menstrual bleeding and iron deficiency anemia, and our role was to rule out a bleeding disorder. Her history, she had heavy menstrual bleeding and dysmenorrhea from her menarche at the age of 12. She wasn't taking any medication or over-the-counter drugs. She was only on oral and IV iron, which she had been getting for the last 2 years on and off. She gave a history that she had a previous hemarthrosis following a knee injury, and she was still experiencing some chronic knee pain, but no other arthralgias. She did have previous physiotherapy for her knee injury, and the story was that she twisted her knee. She didn't have a history of surgery, dental extractions, or any other hemostatic challenges. She had a significant family history. Her mother and her sister both reported heavy menstrual bleeding. Her sister also had a postpartum hemorrhage. The mother had easy bruising, and both the sister and the mother, as well as the patient, reported that they had prolonged bleeding from wounds. On clinical examination, she had signs of iron deficiency anemia, as well as the symptoms. She reported pachyphagia, fatigue, pallor. She had glossitis, and this is her arm, which shows an IV iron stain, which happens when IV iron infiltrates. On clinical examination on the day, she had less than 6 bruises, and she didn't have any petechiae. So my initial assessment of the patient is that she had an iron deficiency due to her increased demand because of her age. She was an adolescent, as well as heavy menstrual bleeding. Now you may wonder, how common is this problem? So 25% of women of reproductive age experience heavy menstrual bleeding, which makes them a high risk group for iron deficiency anemia. And as you all know, iron deficiency anemia is a bit of a public health crisis. So why are adolescents with heavy menstrual bleeding a special group of patients? First of all, because structural causes are less common in this group, and therefore a bleeding disorder becomes more likely. If heavy menstrual bleeding occurs from the menarche, one should also think of a bleeding disorder. Iron deficiency can be more severe because of their additional growth requirements, and it has therapeutic considerations. Surgical options are largely excluded in fertile females. And also the impact of heavy menstrual bleeding on quality of life is especially significant in adolescents. So how do we decide that she has a heavy menstrual bleeding? Heavy menstrual bleeding is defined as more than 80 mils of blood loss a month. So can we simply ask her, are your periods normal? The most likely answer is going to be yes, because she's going to say it's how they've always been, and her mother and her sister and everybody had it like that. However, we need to ask ourselves, what is normal? So the American College of Obs and Gynae defines a normal menstruation as a menstruation of less than 7 days and menstrual product use of 3 to 6 pads or tampons a day. So we actually have to ask her very specific questions to quantify her menstrual blood loss, and these will point out red flags. So if the period duration is longer than 7 days, if she reports changing a pad less than 3 hourly, if she does so at night, if she uses more than 7 pads a day or about more than 21 a month, if there are larger clots, obviously if there's frequent soiling of linen and clothes, and then iron deficiency anemia as our patient had, this alerts us to heavy menstrual bleeding. So the question is, does she need a further workup for her heavy menstrual bleeding? Now, the American Obs and Gynae has a screening kind of tool to decide who needs a further workup. And the criteria is that, first of all, on history, as we asked, there has to be a history of heavy menstrual bleeding, specific questions answered, a history of anemia, if the patient has a family history of a bleeding disorder, or a history of hemostatic challenge with bleeding. And as you will see, the threshold is rather low. You only need to meet one of the criteria. The other question is, does she need further workup for a bleeding disorder? And one way to assess this is by using scoring tools such as the ISTH bleeding assessment tool. And this is the one I completed for her. She did have a positive score of 5. However, as you will see, because she's so young, she's never had a postpartum hemorrhage. She's never had surgery. She's never had a dental extraction. The chance that her score is going to increase as she gets older is something that we need to keep in mind when using these tools. And then I wondered, is there perhaps a specific screening tool for bleeding disorders in women with heavy menstrual bleeding? So what I could find was that on the CDC website, there is this 8-point screening tool. And this is for workup in patients with heavy menstrual bleeding to see if they perhaps have a bleeding disorder. And the tool is derived from a study from 2008 by Philip et al., where they developed this 8-point questionnaire, which had a sensitivity of 82%. However, they found that if they added a pictorial bleeding assessment chart, the sensitivity of the tool increased to more than 95%. Now, this Philip tool, as it became known, was subsequently studied by Zia et al. In 2018. And what they found in adolescents specifically is that it had a high sensitivity, but the specificity was actually low for identifying a hemostatic defect in adolescents with heavy menstrual bleeding. So did our patient need further workup for a bleeding disorder? And the answer was yes, based on her history. So we did some tests for her, and this is her laboratory results. The patient had a severe iron deficiency anemia. Her HB was 5.5. That's low. MCV and MCH were low, microcytic hypochromic. Her ferritin was 3, and the transferrin saturation was 2%. She didn't have any other nutritional deficiencies. On referral, she also had a whole battery of tests done. They excluded hemolysis, screened with PT-PTT, which was normal. Renal function, thyroid, liver functions were all normal. They even did hormonal studies, and these were all normal. So what we did was we sent her bloods for von Willebrand screening, platelet aggregation studies, and platelet function studies, and these were negative. Now, what about a bleeding time? So this is where we are going to do a poll Estelle. We have some options on your opinions on bleeding times, and if you would be so kind, everybody, to pick your answer, I'm going to give it a few minutes. Okay. Yaku, I don't know if you want to perhaps comment for us on the poll.
Yes, definitely very interesting results from the poll, and pretty much I think what we expected people to say. So this is a test that we can perhaps discuss once you've finished this section. Then we can hear perhaps what other people's feeling is on the bleeding time, and we can perhaps debate it a bit. But I'm sure you're just going to give us a little bit of background on where you think this fit into your specific case.
Okay, well, I think in my case, the bleeding time is, I think, one of the only tools that can also be influenced by collagen and the blood vessel itself. So I haven't really gotten to the diagnosis yet, but in her case, if she had an abnormal bleeding time, it would at least indicate that something's wrong. And I think it's something that perhaps hasn't been studied so much in connective tissue disorders, whether the bleeding time will be prolonged in these patients because the vascular wall is abnormal. And it's also considered one of the limitations of the test, as far as I understand. But I think it may play a role there. With regards to the use of the test in general, I'm not going to give any opinion. We can leave that for the end. Okay. Carry on. Now my screen isn't moving. I think it's just a bit slow. Just want to get to the next slide. Okay, so the Guyanese use the palm coin approach to abnormal uterine bleeding in females of reproductive age. So we applied this to the patient. We essentially ruled out structural causes of gynae referral. And we also ruled out a coagulopathy, ovulatory dysfunction, endometrial causes, which are unlikely, and iatrogenic causes. So what we were left with was heavy menstrual bleeding or abnormal uterine bleeding not otherwise classified. But this is not a very satisfying diagnosis for either the patient or the doctor. So to summarize a problem list at this point, she had mucocutaneous bleeding, heavy menstrual bleeding, easy bruising, and prolonged bleeding from wounds. What doesn't fit in so well is a possible hemarthrosis from a knee injury. She had a significant family history of bleeding and a normal laboratory workup. So we get the impression that she has a bleeding disorder. So our final assessment then, is it bleeding of unknown cause? But what else do you want to know? Let's think outside the box for a second. Is there anything else from the history, the examination, or the laboratory that we could ask the patient? And are we perhaps missing the whole picture? like the story of the blind man and the elephant. So I went back to the patient and I did a Biotin score, which was positive. It was 5 out of 9. And this score is a screening tool for hypermobility, and it is scored according to age. So the pictures here are actually of my patient and her mother and her sister. So yeah, she had a positive score, and I'm going to return to how the score works a bit later in the presentation. So a final diagnosis. After ruling out other heritable disorders of connective tissues, I diagnosed her with hypermobility spectrum disorder. So how did we manage her? So her management had a few steps. First of all, we needed to treat the heavy menstrual bleeding. We started her on an oral contraceptive, tranexamic acid. Here again, something we can perhaps discuss is the role of NSAIDs, because they are generally contraindicated in a bleeding disorder, but they have antiprostaglandin effects, which are very good for dysmenorrhea and heavy menstrual bleeding. And here there's a collagen problem. So I'd love to hear if people think we can use it. Vitamin C here plays a dual role. First of all, we give it for better absorption of iron, but because vitamin C is a cofactor that is essential for collagen synthesis, although no randomized controlled trials exist on this, expert opinion in connective tissue or collagen disorders is actually that vitamin C is prescribed. And then the next step, if she does not respond to our therapies, is a Mirena or a levonorgestrel intrauterine device, which is highly recommended. And also, if it were to be available, intranasal desmopressin. So this slide just summarizes, there's a book which talks about hypermobility syndromes and heavy menstrual bleeding, and the recommendations, as I said, are oral contraceptives upscale to a Mirena, vitamin C, tranexamic acid, or intranasal desmopressin. And this table summarizes it again. The only addition here is if you're really in trouble, perhaps to use Nova 7. And then we also gave a pictorial bleeding assessment chart to complete. It just helps us track our response to treatment, especially if it's rather experimental. Then we needed to treat our iron deficiency with oral iron, as well as IV iron initially. And thirdly, general management. So outside a menstrual period, we told her that if her knee pains, she should avoid NSAIDs and rather take paracetamol. We referred her to physiotherapy for hypermobility, education, injury prevention, and rehab. We also gave some information on future surgeries. So patients with collagen problems tend to have delayed wound healing, and they can have wound diseases, and their sutures may need to stay in a little bit longer. Another thing I thought of, didn't read it anywhere, was obviously to perhaps avoid fluoroquinolones in these patients because of the tendon ruptures that can occur. And for support, there's a very nice website that I referred to that you can also look at. It's called hypermobility.org. So this is the management principles, and it's exactly what I said just now. Yeah, so what did I learn from this case? I must remember to think outside the box, and I must also remember to think about the box or the vessel wall or the connective tissues. So this brings me to the discussion, and the first part of the discussion is the bleeding and heritable disorders of connective tissues. Jaco, I don't know if you want to discuss the patient now or after the discussion of the disorders.
Stephanie, I think we can pause there for a brief discussion. We have some time, so I think we'll open the floor now for comments and discussion before we head on to part 2 of your talk. So, any questions or comments from the audience?
Good afternoon, colleagues. It's John here, and thanks again, Stephanie, for that very interesting case. I just want us perhaps to revisit the bleeding time question. Are we going to talk about later, or is this the time to talk about it now?
I think this is a good time. We're not going to return to it.
Yeah. I mean, I wasn't surprised by everyone's impression that probably it's an outdated approach, and it's something that all of us should try hard to forget about. I mean, it has a lot of limitations, and the argument always advanced for using it is exactly the argument that you put, that it's probably the only tool that is able to identify connective tissue disorder. But in my view, it actually lacks the specificity. It does obviously indicate that there is something wrong. That something may well be either a connective tissue disorder or a platelet abnormality of some sort, but it lacks the specificity. In fact, in our setting, we are trying hard to discourage people from ordering it, and certainly we are losing the skill to do it very quickly. I mean, I think part of the reason, and the main reason, is because if you're dealing with a bleeding diathesis of an unknown origin, it is often very difficult to justify why would you, injure someone, and hope that you can make a diagnosis without having a therapeutic intervention. I just thought I'll open that discussion because I think it's an important discussion. It's a discussion that most of us, in fact, are trying hard to bring to the fore.
Thank you, Prof. Mahlangu, for those inputs. Yes, that is you mentioned something important there about the skill of doing the bleeding time. It is something that if you don't do it frequently, you can lose that skill, and that obviously speaks to the reproducibility of the test result. And there are obviously some issues with the reproducibility of the results that can be generated. The other question is often the availability of the blades. I know at our center we tend to still do the bleeding time. We do it much later in the investigation of a patient, almost at the end where we've exhausted all the other possible tests and diagnostic routes. But we've had a situation in the past where we struggled to actually get the surgical blades that are necessary to do the test. And when you do it very infrequently, you do lose the skill. I see Prof. Kutsie's hand is up. Prof. Kutsie, go ahead.
Thanks. Thanks for the discussion. No, the thing is that a gynae registrar did a workup of people who were referred, women who were referred to the secondary hospital, or it's actually a tertiary hospital at Pelanomi, and she did the bleeding time, but none of it was negative in all these patients. So I tend to wonder if you suspect a connective tissue disorder, whether it isn't better to do a validated examination and questionnaire of the connective tissue disorder rather than doing the bleeding time. Thanks.
Yes, Prof, that's a very valid point. And I think also as we move deeper into the 21st century, when we consider connective tissue disorders as a cause for the bleeding, it would be best to actually have a molecular confirmation of the diagnosis to see that you can show the presence of the mutation. So that might be the way to actually think about it instead of resorting to the bleeding time. But it is interesting, and I think it's important that we do discuss it on a national level like we are doing now. Are there any other thoughts on the bleeding time from anybody in the audience?
Jaco, sorry.
Yes, Lariska, go ahead.
Hi, Lariska speaking. I want to give the opposite view. I'm actually quite a big fan of the bleeding time. And like you've mentioned, we use it often in patients that aren't the run-of-the-mill bleeding patients in which the cause of the bleeding is quite apparent. So it's definitely still, for me, a very critical part of our workup for patients with unknown bleeding disorders. And I think we need to know about the limitations of the test. And I think we need to know about the problems with the standardization and the reproducibility, as has already been mentioned. And I agree with Prof. Mahlangu that the specificity is very low. But I think as a screening tool for primary hemostasis disorders, I think the sensitivity is quite good. And just in my limited experience from our bleeding clinic, we haven't found a prolonged bleeding time, which we didn't end up, getting a workable diagnosis for in primary hemostasis. So I want to muddy the water and say that I love the bleeding time and I use it often.
Thank you, Lariska, for bringing us the other side of the coin. I see, is there anybody else who wants to respond to that? I see Jacques has got his hand up. Jacques Malherbe.
Hi, I'm Jaco. Yeah, I think the question that one should ask is, does it add to as Prof. Kutsia maybe alluded to, does it add to a properly performed clinical history and examination and sort of these clinical scoring tools and connective tissue screening tools? I don't have the answer, but I just sort of wonder about that. I've also always thought that it is a test that does have a place in if used correctly. So, but yeah, I think the question is, does it add to other clinical assessments?
Valid point. Thank you, Jacques. I see Prof. Mashlanga has his hand up again. Prof, perhaps one last comment before we head on to part 2 of Stephanie's presentation.
Thanks. I just want to perhaps end with 2 comments. One is, if you are looking after patients with a bleeding diathesis and you do a bleeding time, how do you manage them when they don't stop bleeding? I mean, just to give you an example, and it's very anecdotal. I had a patient whose dad was working in the mines, and this patient would fly into our hospital, the Charlotte Patleke, every time he started to bleed. And my impression one of these days was, let's do a bleeding time. And the bottom line is, this patient, in fact, had a very rare factor deficiency, which would obviously make the bleeding time abnormal. But we ultimately decided that we'll do it together with the dad, who was a doctor, by the way. And in fact, the injury that we inflicted bled more than all the bleeding that the patient had put up with in the last year. And from that anecdote, in fact, I stopped doing the bleeding time. The second point I want to make is, it used to be a very popular test that the neurosurgeons would use as a predictor of how much one could expect blood loss when they are doing neurosurgical procedures. And in my wide reading around that, in fact, there is no correlation between its predictive ability and of course the ultimate outcome of the surgery. So for those reasons, in fact, some of us have held back, and have yet, obviously, if Lariska has got data and information that lends credibility to it, we're more than willing to look at that. But in our center, in fact, we discourage doing the bleeding time.
Thank you, Prof. Very, very interesting. Thank you for that. Perhaps one last question from Estelle, and then we head on to the next session.
Just a point from me as absolutely not a coagulation expert. Indeed, as Johan said, it's mostly used for in our setting by the nephrologists. And I don't know if Jessica is in the meeting, Prof. OP, but I mean, we also do not really use it often. I mean, I haven't been using it in the clinical setting. And in fact, we think, or we believe, and that's also something I've carried from other units, is that perhaps rather doing platelet function analyzing or aggregation, certain different other tests could replace it in a much more sensitive way. But I do take note of what Lariska said. Good for you to come up for the test, because I think the point here is clearly use it where you understand why you're using it. And that's my point.
Thank you, Estelle. I think that's well summed up. Use it where you understand why you're using it. I think that's a general principle for all tests in medicine. Thank you, everybody. So I think let's move on to part 2 of Stephanie's presentation. Stephanie, you can go ahead. Thank you.
Thank you, Jaco. I just wanted to add something to that. Prof. Matlangu, you kind of answered one of my questions, because what I added in the poll was that one of the problems with the test is that they say it's very invasive, and I've seen it done, and I thought, well, it's not much worse than sticking a needle into someone's veins, especially if you struggle to get blood and you have to get 4 blue tubes that are full. However, I didn't realize a person could bleed so much from it, and I think the difference is that if you were to draw blood, there will be some vasoconstriction, which probably makes it a bit less. I just wanted to also, there's some comments and questions in the text box. So Anna-Louise said that she's seen some bad scarring, and I think maybe it could have been a patient with abnormal collagen for that matter. So that's something to keep in mind, a very bad way of looking for that. And then there was a question about a TEG and fibrinolysis, and we're going to talk a little bit about that in the very last part if we get there. So I think I'm going to move on now and tell you a little bit more about bleeding in heritable disorders of connective tissues. So I just need to wait for it to move again. It's as if the screen stops, it wants to not move on. Right, okay, so the first topic is joint hypermobility and bleeding disorders, the heritable disorders of connective tissues. So connective tissue disorders are common, but it's an underreported cause of bleeding. And it's actually a common cause of bleeding of unknown cause or unexplained bleeding tendency. Now, the association between collagen disorders and bleeding was described in 2013 really for the first time by Jackson et al. And they just demonstrated that there was an association between joint hypermobility and bleeding disorders. And they compared the prevalence of joint hypermobility in the general population with patients who attended the bleeding disorder clinic. And they found that 24% of the patients in the bleeding disorder clinic had joint hypermobility versus about 2% in the general population. They use this incidence of 2%, but it varies. Some people say up to 10% of people in the population are hypermobile. Now, you may be wondering, what are the mechanisms? So as you know, capillary fragility can cause easy bruising, but it's a little bit more complicated than that. It's all about this interaction between the vessel wall or the subcutaneous extracellular matrix from Willebrand factor and platelets. So this figure on the right-hand side just illustrates how collagen interacts with von Willebrand factor and the adhesion molecules on platelets to start primary hemostasis. So connective tissue disorders and bleeding. The clinical presentation will be easy bruising or prolonged bleeding, but high rates of heavy menstrual bleeding and dysmenorrhea are reported in the literature, but the association with the collagen disorders is unrecognized. So a few words on hypermobility. It's very common or relatively common in the general population. In order to say someone is hypermobile, the patient must be older than 5 years, and one mustn't make the mistake of misdiagnosing a hypotonic child with hypermobility. It's more common in women than men, and mobility decreases with age. It is frequently seen in athletes and may give a competitive advantage. However, if a patient is hypermobile and has systemic symptoms, then we can call it a disorder. So what are the heritable disorders of connective tissues? This figure illustrates that this is a group of disorders with overlapping clinical features, and they have variable presentations. As you can see, specific mutations have been identified for many of these disorders. However, for hypermobile Ehlers-Danlos syndrome and the hypermobility spectrum disorder, which our patient had, as yet, there is no specific gene identified, and we could best consider these polygenic disorders, or perhaps these mutations will be found in the future. So typically, these patients present with joint hypermobility, skin hyperextensibility, easy bruising, and a variety of systemic manifestations. This figure just illustrates that where at the center there is joint hypermobility, these patients have several musculoskeletal manifestations, including recurrent joint dislocations and recurrent microtrauma, which in the end leads to stiffness and chronic fatigue, chronic pain syndromes. You might recognize some of these patients. On the other hand, there are several systemic manifestations, which I'm going to refer to. So what's the significance of joint hypermobility in collagen disorders? So as we've now discussed, it's quite difficult to screen and test for these problems. And because the joints are made of collagen, it kind of serves as a surrogate marker for a collagen disorder and is something that we can at least objectively assess. Now, this brings me to the next poll. So I'm going to go through the score with you, and I would like to invite you to perform it on yourself and then to write down your score so we can record it. So the Beighton score, I will give some history just now, consists of A, B, C, D, and E part. And each of these is a movement. And if you score positive for the movement, you get 1 point, and you get a point for every side. So if you will join me, for the first one, you actually have to put your arm on a flat surface so that the elbow is also flat, that your wrist isn't bent. And then you need to lift your little finger. And if you can hyperextend it beyond 90 degrees, you get a point for that. So do that one, and then also do it on the other side and see what your score is there. The next movement, you need to put your thumb against the ventral aspect of your forearm. And if you can touch it, then you get a point for that. So touch your forearm with your thumb on each side and give yourself a point if you get it. The next one is hold your arms out, and if your elbows extend beyond 180 degrees or hyperextend, or 10 degrees if you want, then you get a point. If your knees hyperextend beyond 180 degrees, you get a point for each knee. And the last one is only 1 point. If you can put your palms flat on the floor with your feet together, you get a point. It's not enough just to touch your toes. You have to put your palms flat on the floor, feet together. So yeah, if you can quickly calculate your score, and then we'll do the poll. And the next part of the poll is going to be whether you are hypermobile, yes or no. So to be hypermobile, you need to have a score of more than 6 if you are prepubertal, so that excludes most of our audience. If you are postpubertal but less than 50 years old, your score has to be 5 or more to be positive. And if you are older than 50 years, you only need a score of 4 or more. And as I said, this is because mobility decreases with age. So Estelle, I'm going to hand over to you for the 2 polls. First, we're just going to put on our score, and then we're going to answer whether you are hypermobile, yes or no, based on if you're less or more than 50 years of age. Okay. So yeah, let's move on to the next one. We just need a yes or no answer to see if we have hypermobile people in the audience. So if you're more than 50, you need a score of 4. Less than 50, you need a score of 5 or more. Okay, great. Okay. So 12% of our audience is hypermobile, and that is quite in keeping with the general statistics of the population, of the general population. So as you can see, these problems might be much more common than we think. Okay, so there are several screening tools available for joint hypermobility, and a 2017 systematic review recently looked at them and found that the Byton score and the 5-point questionnaire were most widely used. There's still not enough evidence for the validation, but the Byton score is recommended for clinical use. So interestingly, the Byton score was developed, well, according to this paper published by Peter Byton in the 70s in South Africa. And many of you from UCT may actually know him. I see I drew a line on this presentation. I have no idea how to take it out. But anyway, so Peter Byton was a very important geneticist at UCT for a long time. However, interestingly, it was actually his wife, Greta Byton, who came up with the idea for the score. They were sitting around a campfire, but somehow her name actually never reached the publication. So Peter Byton is a very important researcher and a geneticist, especially in the Ehlers-Danlos syndromes and hypermobile disorders. And this fight shift was published in 2016, which is a bit of a tribute to him, if anyone is interested. And I actually kept the book from 2016. I was like a first intern, and I thought this might come in handy one day. And it's actually a very interesting piece of work, just for your reference. Wrong way. Good. So this picture actually I asked my brother to pose. He also gave me permission to show this. So my little brother is hypermobile, as you can see, but for some reason he couldn't touch his toes at all. And I asked his sister to pose there. Now I'm cheating because my feet are not together. And I'm not hypermobile in other ways at all. And I wanted to show you this because my brother has a bit of a scoliosis, and I think that's why he can't touch his toes. And scoliosis is one of the things that are associated with hypermobile spectrum disorders. Now, the 5-point questionnaire asks 5 questions to determine if the patient is hypermobile. And they ask, can you or could you ever place your hands flat on the floor? Can you or could you ever bend your thumb to touch your forearm, just like the Byton score? And then they ask, as a child, did you amuse your friends by contorting your body into strange shapes or do any party tricks? As a child or a teenager, did you dislocate a shoulder or a knee more than once? And then subjectively, do you consider yourself double jointed? Now, I didn't quite understand why one would want to ask these questions if you can just do the screening clinically. But I saw a lady in the bleeding disorder clinic who we strongly suspect has some sort of connective tissue problem. She didn't actually have positive genetic testing done many years ago. She has a family history. Her brother seemed to have ruptured her aorta or something. And she did not have a positive Byton score. But when I asked her, she said, yes, now when she was young, she could put her feet behind her head. And this questionnaire then just gives some historical perspective to make the possible diagnosis. Another easy way is just to ask a patient if they can do any party tricks. So here again is my brother. He can touch his elbow with his tongue. He can touch his nose with his tongue. And yeah, you can ask the patient. You won't have any doubt if they can do any of these things. So a few words on the Ehlers-Danlos syndrome. I'm not going to discuss all these other ones, the Marfan syndrome, Loeys, and pseudoxanthoma elasticum disorders, or Stickler disorders and osteogenesis imperfecta, just to take note of them. But for hematologists, we need to know a little bit about Ehlers-Danlos syndromes. So in 2017, a new classification and criteria was proposed for the Ehlers-Danlos syndromes by the International Working Group. And there is now 13 subtypes. And there's a very nice article for your reference in Hemophilia 2018, where the causes of bleeding in this population is discussed. And on the right-hand side, again, you can see the classification. So for us, hematologists may encounter a patient very rarely, if they're lucky, with vascular Ehlers-Danlos syndrome. These patients tend to die young from aortic rupture, gastrointestinal rupture. They can get a pneumothorax, uterine rupture, tendon rupture. Another one on this is a case presentation of a man in his 20s. So the pictures there are of the same patient when he was 12 years old and when he was 22. And you will note that he has a bit of a specific facies. He has a pointy nose and very prominent eyes with lobeless ears. And then the hand in the picture looks like that of an old lady, but it's actually the patient's hand. And it looks like that because he has this very thin, atrophic, almost transparent skin with visible veins and some ecchymoses. Dermatopraxis ehlers-danlos is also something we need to be aware of. These patients get extensive bleeding and bruising, and it's important not to misdiagnose this as non-accidental injury or abuse. Some of these patients will say they go to casualties and people say, but you're being abused. The hypermobile ehlers-danlos is actually the most common of the Ehlers-Danlos syndromes. It now has a strict set of diagnostic criteria, and as yet, no specific mutation has been identified. And this is in contrast with all the other Ehlers-Danlos syndromes for which several mutations are known. And we can perhaps consider this to be a polygenic trait. This picture, I like this one because it gives some of the clinical features of patients with hypermobile Ehlers-Danlos, but the patient is in crutches. So we tend to think of these patients as athletes, but they are prone to injury, and because of the recurrent micro trauma, they get early onset osteoarthritis. They have chronic pain, chronic fatigue syndromes, and in addition, poor healing, wound healing, and all sorts of other problems which I'm going to refer to. On the left-hand side is on the Ehlers-Danlos Society website. You can get this tick sheet, which has the new very extensive set of criteria for diagnosing hypermobile Ehlers-Danlos, which is essentially a clinical diagnosis. So there's three big criteria, and the first is that one needs to diagnose joint hypermobility. One can use the Biden score or the 5-point questionnaire. Second of all, they need to have 5 of a set of clinical features, and they need a positive family history. And lastly, there's some exclusion criteria. So just some of the clinical features that can be met is that they have these cigarette paper atrophic scars. And then on the right-hand side is a phenomenon called pusogenic papules of the feet, where subcutaneous fat really just herniates through the fascia. And as I said, lastly, one needs to make sure it's not another disorder such as rheumatoid arthritis or another hypermobility kind of spectrum problem. So prior to 2017, the hypermobile Ehlers-Danlos had a very limited set of clinical criteria. And on the right-hand side, many of you will remember the benign joint hypermobility syndrome. And this was diagnosed using the Brighton criteria. This is no longer in use. This kind of problem was renamed as the hypermobility spectrum disorders, and the diagnostic criteria for hypermobile Ehlers-Danlos is now much more extensive. This picture just illustrates the approach. So first of all, in the first block, you have to check for hypermobility. Secondly, the patient needs to meet other criteria and exclude things. And if this is all met, one can diagnose hypermobile Ehlers-Danlos. However, in those patients with hypermobility who do not meet the criteria for hypermobile Ehlers-Danlos, one can diagnose the hypermobility spectrum disorder, which is what my patient had. Then you can also give further subtypes to this, which is a little bit pedantic. And I think the reason for this is that, as I mentioned in another patient, if there is a historical presence of joint hypermobility, a positive 5-point questionnaire, then one can also assign them with historical hypermobile spectrum disorder. So why this new postmodern classification? So we now realize and recognize that hypermobility spectrum disorders are a spectrum of diseases from asymptomatic joint hypermobility to the Ehlers-Danlos syndromes, and that they have several overlapping clinical features. So in hypermobility, the joint dislocations, skin hypersensibility, subluxations is really just the tip of the iceberg. These patients have several other problems, which I'm going to tell you a little bit about. So especially the hypermobile Ehlers-Danlos and hypermobility spectrum disorders are associated with systemic symptoms, and they are best considered multisystemic disorders. The strongest associations, but not the only ones, are with anxiety disorders, orthostatic tachycardia, functional GIT disorders, as well as pelvic and bladder dysfunction. Now, as you will understand, there's also collagen present not only in blood vessels, but in the gastrointestinal tract and the blood and the bladder, and therefore these patients can have problems with autonomic dysfunction. The gastrointestinal disorders can actually be structural or functional. One can examine the patient and look for hernias and even rectal prolapse, and then functional things such as irritable bowel syndrome. You will recognize mast cell activation syndrome from systemic mastocytosis, but this is also something that is seen in the Ehlers-Danlos syndromes. And here the management is really just to avoid triggers and to use medications triggered at mast cell activation. I just included a picture there of Darrier sign again, which is dermatographism, where mast cells are activated when you irritate the skin, really. To understand this a bit better, I just included this picture. The mechanism isn't quite well understood, but as you can see, the mast cells and the collagen fibers are closely related, and they may have some relationship. So by now you may be thinking that you know somebody who has all these different problems: chronic fatigue, chronic pain, anxiety, poor wound healing, irritable bowel syndrome, bladder problems, pelvic floor prolapse, bruising, heavy menstrual bleeding. And it may be a good idea to look if they are perhaps hypermobile. And you will also understand why these patients are often referred from one specialist to the next, and each of them treats the different problem in isolation. And it's almost like the story of the blind man and the elephant, and nobody really sees that the connection between all of this is the collagen. Now, why should hematologists know about joint hypermobility? So as I've alluded, joint hypermobility is associated with bleeding. The very first description of this was in 1998, where Kaplinski et al. Showed that there was an association between hyperflexibility of the thumb and an unexplained bleeding tendency. So it may be a rule of thumb to remember this. I showed you this article in the Bleeding Disorder Clinic, where 24% of patients had joint hypermobility. And then specifically in hypermobile Ehlers-Danlos patients in a pediatric population, 56% of them had a positive pediatric bleeding score. Now, joint hypermobility is also associated with heavy menstrual bleeding. And this is a very nice article you can read by Kendall et al. And they discuss the association between hypermobility and heavy menstrual bleeding in adolescents. So they showed that the impact on school and physical activities in these patients were seen in 60%. Furthermore, they suggest that these patients are likely to have a more complex clinical course, and 68% of their patients required escalation of the initial therapy for heavy menstrual bleeding. And they also demonstrated that there's often a long delay in recognizing these problems. In their patients, there was a mean delay of 38 months between menarche and referral to specialist care. And we also saw this in our patient who was only diagnosed about 4 years after menarche with the problem. This study was done in patients with hypermobile Ehlers-Danlos, and it showed that dysmenorrhea was found in 83%, heavy menstrual bleeding in 54%, and dyspareunia is another problem that patients don't really talk about, but 32% of them had that. Another study in a cohort of 386 women with hypermobile Ehlers-Danlos, 76% had menorrhagia, 72% had dysmenorrhea, and they also showed that there was cyclic worsening of symptoms. Now, this is something else to just bear in mind. We know that joint laxity increases near menstruation, and this is under the influence of hormones. And ladies in the audience may have noticed that they are more prone to injury or stiffness during a certain time of the month. And there was a systematic review which showed that anterocruciate ligament injuries was much more likely to occur at the time of menstruation. So this is really just something to warn a patient about. Now, what are the mechanisms of heavy menstrual bleeding and dysmenorrhea and joint hypermobility? This is actually not very well understood, but the hypothesis is that the abnormal connective tissues and the vascular fragility can actually lead to altered uterine contraction and dysmenorrhea, which will then lead to increased bleeding. Management principles I actually discussed in our case. And this really brings me to an approach to vascular bleeding disorders in purpura. Jaco, do you think we should have a discussion now, or perhaps finish the second topic first?
we can perhaps finish the second topic first, and then we can have a discussion followed by the third section of your talk. Eh?
Okay, cool. Okay. So, approach to vascular bleeding disorders in purpura. So, as you know, hemostasis has several components, and that the vessel wall is an important part of this. So, a patient complains of easy bruising. What does she mean? Now, the picture is actually my leg. I fell at my cousin's wedding, and I thought it was a very impressive bruise. So, yes, a patient complains of easy bruising. Now, we need to familiarize ourselves with a set of terminologies. First of all, what is easy bruising? So 65% of healthy women and 25% of healthy men state that they bruise easily, but this is not actually true. So the characteristics of benign day-to-day bruising, also known as simplex purpura, is that these are never true or palpable hematomas. They are not more than 4 to 6 at the time, generally not more than 3 centimeters. So this is not a bleeding disorder. They're also found to occur on those aspects such as the legs that tend to bump against tables. And I can testify to this. I always have tables walking into me. So this table is a very nice summary of some of the terminologies, and I'm going to talk a little bit about purpura, petechiae, ecchymosis, palpable purpura, bruising, hematomas, vasculitis, telangiectasia. So this is just a paper from the BMJ that emphasizes this point, investigating easy bruising in an adult. You need to ask the patient specifically, what does she mean by a bruise? Do they have a photograph? Is it petechiae? Is it purpura? Was it inflicted by trauma? And is it in proportion to the trauma, or was it spontaneous? So let's say on examination, you find purpura. What does this mean? So purpura means purple, and it refers to the purple discoloration of the skin due to bleeding from small vessels. And there are several types of purpura: petechiae, ecchymosis, and palpable purpura. Purpura essentially is a microvascular problem. There's extravasation of red cells from the microcirculation into the skin or mucosa, and in here the microcirculation refers to the arterioles, the capillaries, and the postcapillary venules. On the right-hand side is the picture of a capillary structure. It consists of endothelium with a basement membrane, collagen, and pericytes. So what are the causes of purpura? This picture illustrates some coagulation disorders, platelet disorders, as well as vascular disorders. As you know, coagulation disorders tend to present with extensive ecchymosis, hematomas, and hemarthrosis. So ecchymosis are large macular purpuric lesions that are generally larger than 3 millimeters. Some books use 2 millimeters. Now, a hematoma and a bruise are not the same thing. First of all, a bruise is a lay term, whereas a hematoma is a medical term. It refers to a palpable lesion, and there's actually bleeding between tissue planes. They're generally larger, and we see them, for instance, in hemophilia, whereas a bruise is a non-palpable lesion. It's smaller, it's a lay term, it's the day-to-day bruising that we all have. What else can cause purpura? So platelet disorders. Platelet disorders, as you know, can have a problem in platelet number or platelet function. So I just wanted to show petechiae to you again and remind you that the mechanism for petechiae is actually that when platelets drop below a critical level of 20 to 30, the cation junctions between the endothelium is disrupted, and this leads to the diapedesis of red blood cells, and these red blood cells can then be seen under the skin. So this picture has a light micrograph of a single petechiae. It is about 1 millimeters in size, and you can see the extravasated red cells in the connective tissues there. On the right-hand side is an electron micrograph, and it shows 2 extravasated red cells. So petechiae, we should remember, is a very specific term used for thrombocytopenia. This is just a picture of a patient that I saw with a platelet count of 1. He had ITP, and he had very impressive petechiae in the dependent extremities where we tend to see them. So palpable purpura is something different. This is just a picture showing that these lesions do not blanch and they are palpable. And the reason they are palpable is actually because of a leukocyte infiltration or thrombin. I'm going to show you a little bit about that. So what makes it palpable? As I said, leukocytoclastic vasculitis with leukocyte infiltration. It can also be microthromby from fibrin deposition, and these are referred to as thrombotic purpuras. So this brings me to the vascular bleeding disorders. Vascular disorders are the other causes of purpura, also the vascular purpuras. Now, there are several classifications and approaches to vascular bleeding. One way of approaching this is to consider microvascular versus macrovascular bleeding. Hematologists will generally deal with the microvascular bleeding, whereas surgeons tend to deal with the macrovascular bleeding. But perhaps a more simple way of classifying it is as inherited and acquired. So the inherited vascular bleeding disorders are the heritable disorders of connective tissues, which we've already discussed, and then HHT. So I've spoken about heritable disorders of connective tissues, but let's say a few words on hereditary hemorrhagic telangiectasia, HHT. I'm not going to discuss this very extensively because my colleague Terence Mutize discussed it last year on this platform, and subsequently him and Prof. Kutsia and Prof. Sidat, I think all of them are perhaps in the audience today, published this paper, and they described the HHT patients in Central South Africa. So again, terminology, telangiectasia are blanchable lesions, and they are actually masses of broken capillaries. They can be caused by several acquired problems as well as the inherited HHT. And in these patients, we characteristically see them on the lips, in the oral cavity, in the nail beds, and in the nose. So I've got 1 or 2 slides on HHT just to remind you. It's a autosomal dominant inherited disorder of defective angiogenesis. It has an age-related expression. In other words, these patients present with epistaxis most of the time, almost 90% of them, more than 90%. This is usually after the age of 12 that they start to bleed, and most of them will have epistaxis by the age of in their 20s. Less commonly, they can have visceral AVMs, and these can occur in the liver, gastrointestinal tract, lungs, brain, and spinal cord in decreasing order of frequency. The diagnosis is made using the Curacao criteria or by identifying a specific genetic mutation. And the complications that these patients had is summarized nicely in this table. The complications result from their specific telangiectasia or AVMs. Nasal telangiectasia causes epistaxis, and basically all these patients have iron deficiency anemia depending on the severity, but our patients in the clinic all come for their IV iron monthly because patients with severe HHT really do not keep up with their iron requirements with oral iron alone. Cerebral AVMs, the feared complication here is as hemorrhage of an AVM with cerebral hemorrhage and stroke. PAVMs are problematic. They cause a right to left shunt, so this can cause a cyanosis and hypoxia, but it can also cause paradoxical embolism and even septic emboli that can cause brain abscesses, and because of the right to left shunt, migraines are also common. Liver AVMs, liver failure can occur, but also high output cardiac failure. And then with gastrointestinal telangiectasia, they can get GI bleeding, and spinal AVMs we're not too worried about. It's less than 1% of patients that have that. Management principles of HHT, to summarize it in one slide, it requires a multidisciplinary approach, and specific management is then started for epistaxis. We use a stepwise approach here. Iron deficiency anemia, which almost always needs IV iron. We need to screen for visceral AVMs, and there's specific criteria, and specific management of the AVMs can then be started. Last year, at the end of last year, the international guidelines were updated, and you can have a look at it. So this brings me to the acquired vascular purpura. Now, there's no specific way of classifying it, but I used this classification from Williams Hematology. It's not specific for acquired disorders, but most of these are acquired. So palpable non-inflammatory lesions are generally acquired. Palpable or non-palpable and inflammatory is generally acquired, whereas the non-palpable and non-inflammatory lesions can then be inherited, such as an HHT acquired. Now, that's a bit complicated. So to make it more simple, they ask 2 questions. They ask, is the purpura palpable? And secondly, is there inflammation? So let's just look at the chart or the flow diagram. Let's ask, is the purpura palpable? And if you say yes, then you ask, is there evidence of inflammation? And then if no, they have a few tables that can be considered. Estelle, do you have a question?
No.
I think your hand is up.
That's an
okay,
old
sorry.
Oh, sorry, that was not the idea. I just
Okay, great.
Excellent.
You can continue.
Enjoying.
Okay, so palpable non-inflammatory purpuric lesions. These include dysproteinemias, thrombotic purpura, embolic purpura, and they include arthropod bites here. So the thrombotic vascular vasculopathies. Here is a picture of what the histology will look like. So there will be a non-inflammatory small vessel of fibrin thrombus. Examples include warfarin-induced skin necrosis, as well as a purpura fulminans. This is just an interesting finding of a patient with PNH who had dermal vein thrombosis and ended up having palpable purpura in the skin. So purpura in dysproteinemias is another subclassification here. So one of the better examples is cryoglobulonemic purpura. So as you know, cryoglobulins are immunoglobulins that precipitate at low temperatures. And there's a type 1, 2, and 3. And then there's a condition called Waldenstrom benign hyperglobulonemic purpura. And Waldenstrom first described the syndrome as a polyclonal hyperglobulinemia with recurrent purpura and elevated ESR and anemia. It's most commonly seen in young females, and it's associated with autoimmune mechanisms. The palpable purpura usually occur in the lower limbs and can cause these confluent collections, as you see in the picture. It's considered a self-limiting disorder that resolves in 7 to 10 days. However, watch out. In pregnancy, it has been associated with adverse outcomes. So don't confuse this with Waldenstrom macroglobulinemia. So Mr. Waldenstrom was a very influential Swedish physician, and he described both Waldenstrom macroglobulinemia and Waldenstrom hyperglobulinemia. And he also classified gammopathies as polyclonal and monoclonal. Now, it's not to say that Waldenstrom macroglobulinemia does not get purpural bleeding. In fact, they can bleed from hyperviscosity syndrome, thrombocytopenia, as well as cryoglobulinemia from the IgM immunoglobulin. This was just a nice picture of a patient with acral cyanosis, which pictures were taken of before and after warming. This brings me to the next set of purpura, the palpable and non-palpable inflammatory lesions. So when you think inflammation, this is essentially the vascular disease, or specifically the cutaneous vascular disease. So the histologic landmark of vasculitis is leukocytoclastic vasculitis. And you can break the word up. Leuko meaning a perivascular leukocyte infiltrate, typically of neutrophils, and cytoclastic, which is really just a leukocytoclasis, which refers to, I actually think it's karyolysis rather than karyorhexis, and it can be seen histologically as nuclear dust. So a little bit on the pathogenesis. What happens is there's immune complex deposition in the small vessels, which activates complement. C5a then injures the vessel wall, and this leads to red cell leakage and fibrin deposition, and then perivascular infiltrate of neutrophils will follow. And in the skin, this leads to palpable purpura. So if leukocytoclastic vasculitis is the histologic landmark, then the clinical landmark of vasculitis is palpable purpura. Now, as you know, the vasculitides are generally classified as small vessel, medium vessel, and large vessel vasculitis, and they can have several systemic manifestations. However, this does not necessarily have to be the case. These pictures are of a patient I saw before I started hematology. I thought it was quite impressive on the hands and the feet and the palms and soles, so I took the pictures and asked her to use them. And she had a cutaneous vasculitis, which was just restricted to the skin with no organ involvement. So causes of cutaneous vasculitis can be primary or secondary. The prototype for primary cutaneous vasculitis is perhaps Henoch-Schönlein line purpura or IgA vasculitis, whereas the secondary cutaneous vasculitises are usually related to rheumatological disorders. Purpura infections can have several mechanisms. The prototype here is perhaps meningococcal septicemia. As in NDIC, there's really fibrin deposition, which leads to skin necrosis. Then lesions initially are red, and then they turn a characteristic gunmetal gray because of the necrosis. Other infections, such as the rickettsia, can cause a direct endothelial infection or their destruction, such as in the viral hemorrhagic fevers, and this can then also cause purpura and bleeding. You may have wondered about COVID. So this figure is from a recently published paper and describes the severity of COVID in correlation with the spectrum of purpuric and vasculitic disorders seen. So it goes from COVID toes to vasculitis to retiform purpura and the more severe forms. And it was recently reviewed in the Lancet, COVID-19 vasculitis and vasculitis mimics, and you can refer to the postulated mechanisms. And the last group of purpura is the non-palpable, non-inflammatory purpura. And you may wonder how can what can be the mechanism? So reduced vascular strength leads to mechanical breakability. And I think of these disorders as an orange, a moon, and a sun. So scurvy is perhaps the prototype disorder. Now, scurvy caused apparently more deaths in the 16th to 18th centuries in the Navy than any other war casualties. And it's interesting, the first randomized controlled trial was done by a man called James Lind in 1747, where he kind of found the cure for scurvy. So on his ship, he had 12 patients and he put them into groups of 2 and treated all of them with different food. And for 2 of the patients, he gave lemon and 2 oranges a day. And he found that these 2 patients got better and so kind of diagnosed scurvy. However, it went unrecognized again, and it was only at the end of the 17th century, at the beginning of the 18th century, where in the Royal Navy, lemon juice and oranges was made compulsory. And it is well known that the Battle of Waterloo was where Napoleon was defeated, but arguably the British defeated Napoleon with lemon juice, because the implication of this introduction into the fleet was that the ships could stay at sea for much longer than before. They had to return to land with their scurvy patients. So by 1812, their fleet had extended to more than 1,000 ships, and they could block the invasion of the French into Britain, and this actually contributed to their winning of the war. So scurvy, ascorbic acid is required for synthesis of collagen, neurotransmitters, and hormones. And these patients clinically can have irritability, neuropsychiatric symptoms, weakness, and pain. 75% have anemia, and this is multifactorial. There are several dermatologic manifestations and bleeding, which I will show. And if left untreated, these patients will invariably die from cardiorespiratory failure and death, and it's not completely understood why. So this picture illustrates some of the dermatologic manifestations of follicular hyperkeratosis, which is surrounded by bleeding and corkscrew hair, is characteristic. The patients can have ecchymosis, gingival bleeding and swelling, poor wound healing. In fact, they say the sailors used to break their bones and break them again because the fractures couldn't heal. And then they can get terrible subperiosteal hemorrhages, which can cause such severe pain that the patient cannot actually walk. So this brings me to a disorder called senile purpura. It's also known as actinic or atrophic or solar purpura. So we see this commonly on the right arm. I don't know if anyone wants to volunteer why we see this type of ecchymosis in senile purpura more commonly on the right arm.
Is that hemisphere specific?
Yes.
Now you can tell us.
Driving?
Yes, that's right. Who answered? Yeah. So
It's me, Amanda.
great. Just tell us why you say so. So driving, yeah. So because your right arm is usually in the sun much more, because we drive on the, which side of the road do we drive? But that side of the road that we drive, that arm is much more commonly on the right-hand side out of the window and gets more sun. So it's much more severe on the right in the southern hemisphere, and obviously on the left in the northern hemisphere. But the point here is that elderly patients will often complain and say, "Doctor, I'm bruising, I'm bleeding." But solar purpura is as common. There's recurrent or cumulative sun exposure, and this leads to degeneration of collagen. The skin becomes quite atrophic, and ecchymosis is easy because of the brittle vessels. This is just a severe form of acute sunburn causing solar purpura. In hypercortisolism, so it's another cause of decreased collagen strength. Cortisol decreases collagen synthesis, and because the collagen catabolism persists, this results in capillary fragility. And it is said that 25% of patients with Cushing's syndrome present, or their presenting complaint is purpura, and one should look for the other signs. Amyloidosis, it can actually cause micro and microvascular bleeding. The deposition of amyloid between the endothelium and the basement membrane will result in capillary fragility and purpura. And what's characteristic about the purpura of amyloidosis is that unlike most purpuras that occurs in dependent areas, these occur along pressure points such as the pericular periorbital purpura, which is characteristic. There are actually also other mechanisms that cause bleeding in amyloidosis. And this brings me to the other mechanical causes of purpura. Here, there's no vascular problem. The problem is intra or extravascular. Now, the prototype here is perhaps suction purpura or hickeys or love bites. This is actually when you apply pressure to the skin, 200 millimeters of mercury of suction is required to cause extravasation of red cells. And this is also seen when patients present with petechia of the face and neck to think about traumatic asphyxia, choking, vomiting, or seizures. And it has even been reported in heavy lifting. Factitious purpura is something to know about. This is really a form of malingering where the purpura is self-inflicted and is found typically in areas that the patient can reach. And then there are some mysterious causes of purpura. So the most well-known of these rare causes is psychogenic purpura, also known as Gardner-Diamond syndrome, where patients have unexplained painful bruising. It's usually associated with emotional or physical stress, more common in females, and worldwide there's been about 200 case reports. The mechanisms are not quite well understood, but Gardner and Diamond, who described the syndrome, called it autoerythrocyte excitation syndrome. But this is one of many hypotheses. And then there's another disorder. I don't know if anyone in the audience wants to tell me what this bleeding is called, or who's ever seen it. So I'm going to give you a clue. The patient is sweating blood. Yeah, so the condition is called hematohydrosis. And what happens here is that the patient sweats blood. And we recently saw a patient like this in the clinic. Leriska will tell you a bit more about it. She saw a patient in the past as well. And both of these young girls had emotional problems. And this hematohydrosis is a rare problem, and it's associated with emotional trauma and is seen in younger girls more commonly. And then there's another condition. This patient is crying blood. I don't know if anyone knows the name for this. So this is called hemolacria. And this is also seen in younger girls with emotional or physical trauma. And it's literally the body's way of saying, help me, I am crying blood. Yeah, so that's the end of vascular purpuras. Jaco, we can perhaps have a discussion now.
Yes, Stephanie, I think let's hear from the audience if there are any comments or questions. Stephanie, while people are thinking, you mentioned that you should test the skin for hyperextensibility. Can you perhaps just explain to us how you actually do that practically, how you clinically test for hyperextensibility of the skin?
Okay, Jaco. So there are more than one way of doing that. What they describe is that if you try and lift the skin on the ventral forearm, if it lifts more than 1.5 centimeters, or the volar forearm, then you can say it's hyperextensible. But then I found a very interesting thing I'm going to show you in this video. This Zeitschrift. There was a little anecdote by one of the students of Professor Bison, and he described here how they developed a mechanism for for measuring skin hyperextensibility, and they kind of made a vacuum and wanted to use it in scleroderma, but it didn't work very well there, but they found that it worked quite well in measuring skin hyperextensibility. And he describes his own personal method, which he said was never actually published or accepted anywhere else. But what this, I'm just going to tell you who it is. Professor Graham says the way he measures it is lifting the skin on the dorsum of the hand. Now, you will notice my skin seems to be quite hyperextensible, and you may do it on yourself and see, like, how do you know it's hyperextensible? So what he says is if you lift the skin and it extends beyond the wrist or around the dorsum of the hand, then he considers the skin hyperextensible. And as I said, the other way is looking at the volar forearm, and if it lifts 1.5 centimeters, it's considered hyperextensible.
Thank you. So on the back of your hand, you should actually then lift it up longitudinally as well as transverse, and then if it extends across the hand, then you are possibly hyperextensible.
Okay. Yeah, exactly.
That's what you're saying. Okay.
Yes.
Okay, great. Any questions for Stephanie at this point? Stephanie, if I can maybe just see, there's Prof. Kutsia has got his hand up. Go ahead, Prof. Kutsia.
Hi, Stephanie. So how aware should we actually be? Should we sort of start special clinics for this or something? Can you put in clinical perspective, please?
Okay. Well, my very junior clinical perspective is that from the reading that we did is that it's an unrecognized problem. So we can't really say how common it is, but there were studies that showed that especially the heavy menstrual bleeding and the dysmenorrhea is quite common in especially the hypermobile Ehlers-Danlos. 70 to 80% is a high incidence. However, in the patient we had with the hypermobility spectrum disorder, there isn't really that much data. But as we saw from the poll, and that's why we did it, in our audience, there are 12% of the people who are hypermobile. And I don't know if they don't have to comment or tell us anything, but it is highly likely that that might not be the only problem that they have. So my answer to this is that in the patients that I see with bleeding problems, with a normal workup, with nothing else, the least you can do is to do a Brighton score to see if they're not perhaps hypermobile. And for now, the management is not that much different, except for the addition of vitamin C that is recommended in these patients. With regards to the other genetic disorders, there are incidences for them, and they are very rare, and it's best to refer these patients to genetics or a rheumatology clinic for further management and diagnosis. But what I found often is that in hematology, patients end up with us, and we cannot always just say it is not a hematological problem. And it's just a nice way of saying, yes, I think this can be something else, and then refer them appropriately.
Thank you, Stephanie. Perhaps just one last question from me. You mentioned scurvy, and it's obviously a condition that has had a great influence on the history of the world, but how common is it these days? Did you find any data on the prevalence or incidence of scurvy in the 21st century?
So I've never seen a patient with scurvy. I don't know if anyone in the audience would like to perhaps tell us or comment in the box if they've seen a patient with scurvy, but I kind of looked it up in South Africa. How common is it? I expected that it would be because we have so many malnourished patients, but there isn't really data on the incidence or prevalence in South Africa that was published anytime recently. But in America, what I could find was that they did a national survey in the 2000s and found it to be more common in the elderly, and the prevalence was about 7%. So it's not very high. However, one wonders if in a country like ours, where we see so many malnourished patients, if it's not more common than we know. And the other populations we should think about this is chronic alcoholics, and then perhaps patients on a very strict Banting diet who do not take any other vitamin supplements. I don't know if anyone in the audience would like to add something on scurvy that they perhaps have seen before.
Thank you, Stephanie. Estelle has reminded us that we are unfortunately out of time. So I would suggest that we perhaps reschedule the third part of your talk for another day. I think it was a truly excellent presentation, and I would hate for you to rush through this last bit in a few minutes. I think to do this topic and the quality of your presentation justice, I think we should reschedule this third part. So unless there are any objections from anybody in the audience, I think we'll arrange then for Stephanie to give this third part at a later session later in the year. So just in closing, are there any last comments or questions on either of Stephanie's two presentations now from anybody in the audience?
I have no comments. I just think if there are anybody who really want to contribute some viewpoint from their center or so, please go ahead. I think, we still, a few minutes won't hurt. Let me perhaps give one point of view just from our side is I have never looked for Ehlers-Danlos in somebody with menstrual bleeding, and I think most others haven't. Marius is asking a question about molecular testing, but we have seen that now that we start looking for HHT patients, we find more and more and more of them. We find that people we train in medicine find them in casualties. So it's really a case of looking for them. So that's just from my side. Really, really very interesting. Very well done.
Thank you very much. I really enjoyed it.
Yes, I agree, Estelle. Thank you very much. I think with that being said, if there's no other questions or comments, Estelle, shall we close the session?
Yes, let's do it. And I will keep it open for a minute or two if somebody wants to still add their names. And thank you, Bloemfontein. Wonderful presentation. And a good afternoon to everybody.
Thank you, everyone. And once again, just from our side, thank you to Estelle and the team for inviting us to speak here. And thank you to Stephanie for a truly excellent presentation. And also thank you to everybody in the audience who took time out of your busy schedules to join us here for this really interesting and important discussion. Thank you very much, everyone. Have a great evening. Bye-bye.